Greetings and welcome to the virtual roundtable on data approaches to improve efficiency and access to cancer care. This is a really exciting and important moment, and we're all looking forward to a rich conversation with some incredible panelists today as we reflect upon some of the key challenges related to data and how addressing those challenges can improve access and increase efficiency of cancer care. As we know, there is a growing and aging population. Cancer is an increasingly important burden of disease in many countries, and particularly in lower and middle income countries, LMICs. There is a lot of struggle at the health system level to overcome the challenges that cancer creates within a healthcare system, particularly from a financing standpoint. There are many opportunities to increase the efficiency of a health system and lead to better outcomes for patients, and also to think about how different levels of data must be considered from a systemic, population, and individual health perspective. We know that these are a lot of different challenges, and there are many ways that we can address this. I want to also make sure that we have time to introduce the panelists and myself. My name is Margaret Cornelius. I'm a Deputy Director for the Private Sector Program at ThinkWell, which is a global health systems research organization specializing in health financing and health systems improvement, and working to increase the path and the rate of achieving universal health coverage around the world. As I noted, we have a number of panelists today who are going to help us really think about some of these data challenges and how to overcome them, particularly looking at the lower middle income country setting. We'll hear from Thomas Hofmarker, who is a researcher at the Swedish Institute for Health Economics, and whose work, of course, will be familiar to many as he is one of the leading experts on cancer financing around the world. We're also joined by Damien Walker, who is a health economist and data scientist, and currently serving as a practice area lead for healthcare financing and as a senior principal technical advisor at Management Sciences for Health, which is an organization that's committed to increasing how systems perform and improve access to many, many people around the world. We're delighted also to have Dr. Timothy Hanna, who is a researcher at the Ontario Institute for Cancer Research. Dr. Hanna's research is wide-ranging and very exciting, focusing on 3 translational streams of health services research. Of course, this is spread across quality, value, and access to care, critical topics, all of which are very rich. And finally, we're joined by Alpan Raval, who is the head of data science at Waiwani AI, which is an India-based organization working to apply AI to impact the greater social good. It's incredible to have these folks with us today. Can't wait to hear more from them. In terms of how this session is going to go, we'll first hear from Thomas, who will take us through some of the data approaches and challenges to improve efficiency and access to cancer care. And then I will invite the panel to reflect and share some of their own experiences and reactions and help us all understand what we can do in our own settings to really focus on fixing some of these data challenges and understanding how those investments in solutions for data can actually benefit patients and populations down the road. Thank you, Thomas. Over to you.
Thank you, Margaret, and thank you for inviting me to this session. So in the next few minutes, I will try to give you my take on what data do we have to monitor the efficiency and effectiveness of cancer budget allocation today. And I will be drawing on 2 research projects that my institute has been conducting recently. So let's start with the first one, data to monitor the effectiveness. So effectiveness in general is the degree to which something is successful in producing a desired result. Now, what's a desired result in cancer care? As you know, cancer is one of the leading causes of death worldwide, and therefore survival is really one of the prime measures of measuring effectiveness in cancer care. And here in this slide, I'm showing you the example of breast cancer in some countries in the Middle East and Africa compared to Sweden, looking at survival rates. The graph to the left shows you the 5-year survival rate based on data from the Concord 3 study by the London School of Hygiene and Tropical Medicine, which estimates that breast cancer survival is somewhere between 40% and reaching all the way up to 99% in Morocco. Now, if you would believe this data, it would be fantastic if Morocco could achieve a 99% survival rate, far higher than Sweden, for instance. But can this be true? Looking at another data source, GloboCan data that the WHO is behind, we calculated a proxy for survival based on the complement of the mortality to incidence ratio. And there it seems that survival might actually be somewhere between 60 and 80% in all of these countries, and Morocco in particular, probably among one of the countries that ranks lowest here. So the question is, for Morocco, how good is cancer care? How effective is cancer care? What kind of outcomes are we really getting here? And the answer is we don't really know. So what's needed to overcome this challenge? We need population-based cancer registries to provide robust and local survival estimates. That should be a priority for all countries. And in order to achieve good outcomes in cancer care, what you need is inputs. So you need the inputs to achieve desirable outcomes. Here I'm showing you two examples of inputs. One is cancer drugs, and the other one is radiation therapy machines. When it comes to cancer drugs, so the graph here shows you how much countries in Asia Pacific are spending per capita. And you see that in India, for instance, it's $0.2 per capita per year that are spent on cancer drugs. And then you have China with $5.6. And similarly, for radiation therapy machines, in Algeria, there's less than one machine per 1 million inhabitants, whereas in Lebanon, it's about 3 machines per million inhabitants. And in general, you could think that higher numbers here on these charts probably means that more inputs are available. So that should be good for achieving good outcomes. But it's a crude picture that we get from the data that is available out there from the public available sources, really. Because one point that always needs to be considered is the inequalities in access to these inputs within a country, because they can be large. If you think of geography, for instance, rural areas always have worse access than urban areas when it comes to radiation therapy. But also in many countries in this setting, in the lower middle income countries, the absence of universal health coverage is a big challenge, because if you look at spending on cancer drugs in China, well, it's close to achieving universal healthcare now with more than 95% of the population covered. But in other countries, you don't have universal health coverage. So just comparing raw numbers between countries really does not give you the full picture, because it's only often that some population segments have much greater access than others. And this is something that this kind of aggregate data cannot really tell us more about. Now, the final point is about efficiency. Efficiency is really whether healthcare resources are being used to the best value for money. So it's really putting together how much are we investing in cancer care and what kind of results do we achieve. So combining these two aspects, that's efficiency. So in terms of spending on cancer care overall, the data are really bleak. There's hardly any data available for, not even for high income countries. So it's difficult to say how much we're spending on cancer care. But we provided estimates for the Middle East and Africa, for some of the countries there. And what you see here is, for instance, when you look at Jordan, we got an estimate based on published data of $51 per capita that is spent on cancer care. But then we talked to local experts that said, no, we believe actually that we're spending more on cancer care. So maybe $87 per capita is a more realistic estimate. And the importance here is, if like, that's quite a big difference, 51 and 87, because if Jordan were to spend $51, then compared to the other countries that you see on this graph, it might seem that cancer care is fairly efficient compared to the other countries. But if it would spend $87 indeed on cancer care, then it's definitely not efficient, because countries like Kuwait, Saudi Arabia, or the United Arab Emirates achieve much better outcomes for cancer patients. But again, the issue here is really, since we don't have good information on how much we are spending on cancer care, and also not on how good outcomes do we achieve, we can never be really sure on how efficient we are in terms of using the money that we're spending on cancer care in the best possible way. So what's needed here, it would be more efforts towards introducing disease-specific health accounts. The OECD has recommended this. The WHO has also encouraged countries to look into this issue in order to just give us some better information on how much we're spending on cancer and also other diseases. And this should ideally actually build on sort of disaggregated individual level data, where you have patient records that you link to the cost of interventions that you give to patients. And then also you need to record the outcomes that patients achieve. That would give you a full picture, and that will make it easy to improve efficiency in cancer budget allocation. Thank you.
Thank you so much, Thomas. That was a lot of information, and I'm sure that folks will want to see your research as it comes out. This is incredibly interesting. I want to pick up on your point about equity. Often economists, and I'm one of them, we tend to talk about effectiveness and efficiency, but we lose the third component of that important triangle, which is equity. I want to hand the floor to Damien, given the work that he's doing in primary care, and invite him to reflect a bit on equity challenges that he sees and how solutions in the data space might help us think about equity more broadly. And to your point, Thomas, make the inequities more visible and therefore more addressable in health systems for cancer. Damien, over to you.
Wonderful. Thanks very much, Margaret. And thanks, Thomas, for that wonderful presentation. I'm going to pick up on some of those themes that you presented there, and obviously also introduce this concept of equity as well. I wanted to think about three buckets of data. And the first bucket is going to be burden data. And you've mentioned a bit about that already. And I think we need good burden data today, but also forecasts of what that burden will be in the future as well. The second bucket of data is around interventions as well. And there's three specific types of questions that I think we need data to answer. What works, what's worth it, i.e. what's cost effective, and then what's used, where and by whom. So questions around access and coverage. And this is where the concept of equity is going to be introduced. And then the third bucket of data is around financial data. Who pays? And specifically in LMICs, I think it's important just to break it down into three other buckets as well. Governments, donors, and individuals and households, so out-of-pocket payment as well. So I'd like to go through each of those buckets quite quickly here. So in that first bucket around burden, I think we actually now have some really fantastic data. So for the last 3 decades, the University of Washington, specifically the Institute for Health Metrics and Evaluation, led by Chris Murray, have been producing estimates of the global burden of disease. And every 2 years, those estimates are now published in The Lancet in a series of articles. I'm sure many of you have read those articles and pored over the appendices that are attached to those articles as well. So we now have quite granular data in terms of who's dying, where they're dying, and from what. And specifically for this audience, we have relatively good data now from IHME on cancer, broken down by the different types of cancers. I think the big issue with that, whilst it's a wonderful resource, these are model estimates, and there is a danger that through these model estimates, these model endeavors, we are papering over the cracks in our data and data systems. I was struck by a statistic that WHO released earlier this year, which said that just 1 in 10 deaths are recorded in the African continent. And so when it comes to causes of death, we know even less. I just want to relate this back to the COVID pandemic. I think this may be a silver lining of the COVID pandemic, that there are calls now to invest much more heavily in these vital civil registration of vital statistics systems as well. I think there are entry points as well that are perhaps lighter touch to begin with as well. And I know the Bloomberg philanthropies are beginning to experiment with rapid mortality surveillance as well, which is an entry point into these larger systems that are much needed in many LMICs as well. So it's a good news, bad news piece when it comes to burden data. When it comes to that second bucket around data on interventions, what works, what's worth it, and what's used, where and by whom, I actually think, again, we have pretty good data on this. And so every 5 to 6 years or so, there's been a very large project, again, led out of the University of Washington called the Disease Control Priorities Project. And the third edition of that book was published a few years ago. And on this occasion, it wasn't a single book, it was a series of 9 books or volumes. And the third volume was on cancer. And so in that book, they synthesized an awful lot of information. They synthesized what we know about the burden, what we know about interventions and how they work, and which of those interventions are cost effective. And of course, they went ahead and published some wonderful papers in The Lancet. Now, I think that the concern I have with this effort is that all that information has been synthesized. My concern is that it has not been adequately translated into policy and practice. And I think that is the big gap that we face. And so one of the efforts that my organization is involved in, I know a number of other partners are involved in this as well, is trying to stand up priority setting institutions in countries. If you will, NICE-like institutions, borrowing from what England and Wales have done now for 2 decades as well. And I think if you have those processes, those institutions in place, they can really help inform decisions at the margin, so which new cancer drugs should be adopted and paid for, reimbursed. But equally as well, and this is the other area where I think there's a real need for value add, what should be part of the health benefit plans as well, and where should cancer care interventions fit within that as well? And again, those types of priority setting institutions can really help shine a light on what we know and kind of level the playing field, if you will. Finally, on who pays, I really don't have much to add on this one, which is Thomas's point. We don't know very much at all, unfortunately. Again, there are a variety of sources of data. Thomas mentioned the OECD. I'm more familiar with the WHO data. Again, IHME as well. When it comes to cancer data, I was looking at the National Health Accounts that WHO has been trying to institutionalize over the last 5 or 6 years. There's no cancer data. They're even struggling to get granular data for, let's say, the big 3 diseases, TB, HIV, and malaria. So they just haven't yet gotten to the point of incorporating many other diseases, but that's urgently needed. And I guess my concern again is that without those systems in place to actually collect real data on what is being spent and by whom, we end up relying a little bit too much on some of these modeled estimates. And I think over time, there's a danger that we begin to believe a lot of those model estimates and forget to invest in these systems that are much needed as well. So this is kind of a common theme in my remarks. Model data are fantastic, but I think we need to ensure that we're investing in the systems that are going to enable us to have better data over time as well. Margaret, you did ask me to spend a bit of time on equity. Let me come back to that now. And I think this is, again, one of those areas where if we have better financial data, in particular, if we have better data on how much families are spending out of pocket on cancer care, we can begin to understand the extent to which cancer care can be impoverishing for families and households as well. And I think when we begin to think about universal healthcare now, obviously financial protection has become one of the main targets to achieve as well. And I think without better data, it's really hard to know to what extent you're achieving some of those targets. So I'll pause there and hand it back over to you, Margaret. Thank you.
Thanks, Damien. So many excellent interventions and points. And thank you for reminding us and our audience about, it's not all bad. There's a lot out there and tremendous investment on the part of many institutions, many academics, many researchers. So on that note, now that we've heard from sort of the economist corner of the world, Tim, I would love to invite you in and have you share with us and reflect upon some of your own research and observations around data from more of like the clinical and health services research space, and think about how these things are all part of a big universe and all need to work more symbiotically together. Tim, over to you.
So thank you, Margaret, and it's a pleasure to be here. Thank you so much to Thomas for setting the stage with that excellent presentation that really identified some of the key issues in international global data, and Damien for those very important remarks on elements of data, specifically in health economics and evaluating efficiency and other aspects of care. So I'd really like to pick up on what Thomas spoke about the variation in cancer mortality and trying to measure survival. And you know, when we look at trying to measure this outcome, the way that we do it can produce very different results. And so I think it's important to understand and pick up on some of the points made that we need to have a reliable denominator in order to answer our questions effectively. There are many places in the world that have high quality population-based cancer registries, and this is an amazing achievement. However, when we look at where those registries are and what they cover, it can be less complete than we would want. For example, in the continent of Africa, there were 7 registries that met the quality criteria for population-based cancer registries in IRX cancer incidence in 5 continents. So those population-based registries give us great information, but the coverage isn't as ideal as we want. So for example, thinking about equity, if we want to measure what people's access is to cancer care, then we need to provide coverage of registries that goes beyond large cities and covers area where equity could be a concern. We don't have to have a population-based registry that covers the whole country, but we need to cover even small areas well so that we understand what the overall denominator is in cancer incidence and measure mortality, really, if we can, in those areas well. It's incredibly important also to think about the data infrastructure and the data ecosystem that allows us to perform these analyses. So it's not enough simply to have the available data. I live in the Canadian province of Ontario, where we have extensive population-based linked data on a universal healthcare system. We can cost every single interface that an individual has with the healthcare system. And that costs a lot of money and takes a lot of infrastructure, but it's reaped incredible rewards in guiding our system. However, at the same time, there are pockets of data that are not used at all, and it's an incredible waste. And so when we're thinking about what's appropriate in low and middle income countries, we need to both think about what questions we need to answer, but also that we have the ability to answer those questions well with adequate analytic capacity that's planned and targeted towards those questions that most are in need of answering. Other things that are important to think are interoperable data standards, for example, and that's an incredible opportunity for global organizations to think about how they can provide leadership both in low and middle income countries, but also in high income countries. It's an issue that we struggle with internationally, and if we can start to standardize better how we measure aspects of care, that will allow us to answer the big questions that we need to answer in oncology. Precision oncology is a big area, but this isn't the only area where having high caliber, high number data is incredibly useful. So I think I'll end there, but really emphasize the importance of that ecosystem and the governance of good data to achieve it.
Thanks, Tim. Really amazing. And I have to say, as someone who's sitting in the US, hearing all of these fantastic population level data systems that the Canadian system is using, I feel a bit of envy. I want to now turn to Alpan, and I suspect, Alpan, that in many of the settings in which you find yourself, You hear a lot of conversations like this, and then the moderator says, okay, can AI fix all of these problems? Kind of like, the solution for resource mobilization is Bitcoin, right? Or cryptocurrency. So Alpine, you work in an incredibly data-rich data space in India, where the infrastructure is incredible, but also very challenged. And yet you all are breaking through with some truly incredible approaches and innovations. And I would just love to give you the floor and the freedom to reflect on what you've heard today, and also share with us what you're hopeful about and where you think AI might help in addressing some of these challenges, from efficiency, effectiveness, and probably as importantly, equity. And I know that that's really true to your organization. So please, over to you.
Thank you, Margaret, for inviting me for this session. And thanks very much to all my fellow panelists, Thomas, Tim, and Damien, for those really wonderful insights. Yes, so this is an interesting question on sort of AI in low and middle income countries, and how AI can, on the one hand, change the public health landscape, which may be a tall order, but also on the other hand, be part of the data challenge solution. So, usually it's well known that, the information flow goes the other way, that AI typically relies on high quality data, and a lot of it, in order to build effective models for various things. But what may be less recognized, and is perhaps more relevant in the developing world, is that AI can in fact be part of the data solution itself. So for example, we at Wadhwani AI, we work on the development of AI solutions in public health, among other domains like agriculture as well. And there's at least two ways we found where we can leverage AI technology to improve the data landscape, especially the public health data landscape. So first, AI can be used as a means for digitization, as a means for actually collecting data. And one example is, the work we do in maternal and child health. What we built at Wadhwani AI, for example, is a computer vision-based model where you can take a picture, a series of pictures or a video of a baby, sort of a newborn baby, and measure its weight. And you can do this in the home setting. It's sort of a touch-free solution. The mother doesn't have to travel all the way to a possibly distant hospital or a health clinic. And this can be done by health workers who don't have to be very well trained and are on the field. And the idea is to make, we call this a visual weighing machine. And the solution, if we can, it's still in development stage, if we can get it to the level of accuracy to be usable in the field by non-expert healthcare workers, it's going to simultaneously solve two problems. One is the problem of accurate weight measurement and weight tracking of newborn children. But also, on the other hand, the accurate logging of data in digital form in the back end, so that there is no data tampering possible. And this problem of accurate logging, data tampering, and so on is huge across the global south. And this is one way AI can help. And it's possible that such symptomatic measurements may be useful in other types of healthcare situations through the use of computer vision. So we see this as one sort of pattern, using AI as a measuring tool for various things. The second aspect where AI can help and sort of be part of addressing the data challenge is that just the very existence of AI technology provides back pressure on systems to ensure data quality. I completely agree with Damien when he said, COVID has changed the data landscape to a large extent. And part of the reason COVID has changed the data landscape, especially in countries like India, is that there's been a raft of models to predict, COVID outbreaks. And these models require data. And there's been back pressure on systems, on public health systems to produce good data as a result. And since the performance of, especially when you have AI models, and since the performance of AI models degrades very rapidly with poor quality data, Once you have a reasonably good model in deployment that's being used in a public health setting, and there is stakeholder alignment on adoption of the model, then there's also alignment to make the model do better, so to speak. And that translates to pressure on data systems because these models are data hungry, they require good quality data. And so just having stakeholder sort of motivation to make these models better actually pushes data quality as well. And we are noticing some of this in our TB work where we can explicitly show in limited settings that models for predicting, for example, adherence to TB medication, they improve drastically in terms of predicting risk scores when the data is of higher quality and when the data is more complete. And we use that to generate data quality reports, and that can be shared with the Indian government to, hopefully to improve policy on the data end. Now, of course, having said all this, I'd also like to add that AI is not it can't be taken as sort of the solution to data issues by any stretch. By and large, it's still true that better data is valuable, whether or not you intend to use the data to develop AI technology. And in fact, and especially in the healthcare space, it's important that AI solutions, for various reasons, be used as solutions of last resort and not as solutions of first resort. We know that computer vision techniques have proved very useful for automating aspects of radiology work, and predictive analytics is very useful for things like risk stratification, guided interventions and triaging and so on. But it's important to know the limitations and only use AI where it's really needed. So it's important that it should be thought of as a hammer in search of a nail. And I always emphasize this in my, whenever I'm sort of interacting with public health organizations for using their data to do AI work. It's very important that we learn to identify problems that are amenable to AI. We create models that are interpretable and respect privacy. And this is sort of a very big issue: interpretable, fair, and respect privacy. So I'll pause there.
Thanks, Alpan. I'm a little disappointed that AI isn't the panacea, but I appreciate you reminding us of all of that. And I'm struck by a comment that you made, and then I actually want to give Thomas the opportunity for some final remarks since he set us up and should therefore have the right to close us out. One thing that really struck me is that the value of data is sort of mutually reinforcing. Like the better quality it is, the more valuable it becomes and the more demand for it you might have. And I think particularly the examples that you called out in India bring me almost to my own context where the data that people are talking about, just non-public health people, in the COVID context, I have never in my life had so many conversations with just regular people about data and what is it telling us and how can we use it. And I do think, using Damien's term, that there is this silver lining, there is this window that's opening where the public eye has never been so focused on public health data and the importance of data. And I'm hopeful that both for cancer and many other diseases that end lives too prematurely or complicate them unfairly, that we can leverage, right, this moment as a community and really bring all those things home to people who otherwise wouldn't be paying attention. Thomas, I want to offer you the floor, and maybe you can close us out. Just what are your reactions to some of these interventions from your colleagues?
Well, first of all, let me thank the other panelists for sharing their thoughts. That was really it was an enriching discussion, I think. But what really strikes me is that that COVID-19 really sort of shifted the focus when it comes to data, and also making all countries around the world aware that they are able to provide up-to-date data. I mean, what we did is eventually move towards real-time monitoring of a disease. I mean, in cancer, we have statistics that always are 5 years old in some countries, or there are no statistics available at all. But in COVID, we were able to do real-time monitoring. and policymakers could really understand the impact of their works, because when they imposed a lockdown, then it was very easy for them to track how incidence rates developed, so they could see directly the impact of their actions. And that's also what we need for cancer, and we need this actually for all other diseases as well. So I really hope that there's a big spillover from COVID to all other diseases, and hopefully policymakers just won't forget the importance of ensuring this kind of data is available. Thank you.
Thank you, Thomas. And thank you to Alpan, Tim, Damien, the organizers, to UICC for helping to convene this excellent panel. It was really a pleasure to hear from all of you, and I'm sure that we will be one of the top views in the Cancer Summit, because this was just an excellent intervention. And all of these panelists can be found on LinkedIn or other places, and I hope you will continue to reach out and follow their work. And I hope that we can all meet sometime in the future soon, and it was great to be with you today. Thank you.
Thank you.
Thank you.